Sylvia, it's nice to do it with you.
Yeah, it will be nice to watch your presentation. Yeah.
I appreciate we're doing it together.
Mhm.
So in 1 minute, I'll put the slides, right?
Yes, yes, exactly. Yeah, and then I'll start. Yeah.
You can tell me, put the slide. I have 31 now. Yeah. We have.
You can put the slides now, Nabila.
Let's see if I can wait.
Good morning, everybody. I'm Sylvia Martins. I'm a professor of epidemiology at Mailman School of Public Health, and it is my pleasure to introduce the speaker of today's webinar, Dr. Nabila El-Bassel. She is a university professor at Columbia University School of Social Work and also the director of the Social Intervention Group, a multidisciplinary center that focuses on developing and testing effective prevention and intervention approaches to address the drug overdose crisis, HIV, and gender-based violence. Dr. El-Bassel is also the director of Columbia University's recently established Center for Healing of Opioid and Substance Use Disorders, CHOSEN, and she is a principal investigator on the NIH-funded Healing in Community Study, HCS, which aims to reduce opioid overdose deaths by 40% within 3 years in 67 communities in 4 states, New York, Kentucky, Ohio, and Massachusetts. It is a joint effort by Columbia School of Social Work, the Department of Psychiatry, and Mailman School of Public Health, also the Data Science Institute, and it also includes a number of researchers from other major universities in the area. With main offices in New York City and Almaty, Kazakhstan, Dr. El-Bassel also directs Columbia University's Global Health Research Center of Central Asia, where she leads a team of prominent faculty, scientists, researchers, and students who are committed to advancing solutions to health and social issues in the region through research, education, training, policy analysis, and dissemination. Most importantly, over the past 25 years, Professor El-Bassel has designed and tested many cutting-edge, multi-level HIV and drug use prevention and intervention models for women, men, and couples in diverse settings, such as drug treatment and harm reduction programs, primary healthcare clinics, and within the criminal justice system. She has published extensively and has made a significant scientific contribution to the fields of addiction, HIV, and gender-based violence research. She has published in JAMA, New England Journal of Medicine, Lancet journals, and more journals. So today, Professor El-Bassel will focus on one study, which is called the Healing Community Study, a multi-site study that focuses on reducing drug overdose deaths in 40% in 3 years in 67 communities using the science of community engagement. It is a pleasure to have you here today, Dr. El-Bassel.
Thank you very much, Dr. Martinez. It is really a great pleasure and honor to present today at this forum. But before I begin my presentation, I want to express my special admiration for the mission of the Columbia Commons Interprofessional Education program that promotes a better healthcare for patients and their communities. I truly believe in the power and the value of multidisciplinary perspectives and collaboration. I have been promoting and pursuing multidisciplinary collaboration in research, as Dr. Martinez said, for more than 25 years at the School of Social Work, but also at Columbia University. As Dr. Martinez said, I focus on issues that critically impact many communities. I focus on addiction research, drug overdose, trauma, gender-based violence, and HIV. The talk today that I'll focus on, as Dr. Martinez said, will focus on one study which focuses on community-based research to reduce overdose deaths in 40% in 67 communities. I also want to say death from drug overdose has been increasing in all our communities. It has become so common that each of you here today likely knew someone, a friend, neighbor, a relative who has died from drug overdose. I do know people in my network who died from drug overdose. So what I'll do in the coming 45 minutes, first I want to talk to you about how big is the opioid and drug overdose death in the United States. I want to focus on the Healing Community Study, which is a community engagement, data-driven approach to deploy evidence-based practices in 67 communities. I want to give you a few examples how we deploy evidence-based practices in the healthcare settings, how we involve law enforcement to deliver and deploy evidence-based practices. And I want to talk to you about how we reduce stigma to make people access treatment. And I want to focus on a model that the Healing Community Study has been using. So let me start by saying a drug overdose have killed almost 1 million people since 1999. And if you look in 1 year, in 2020, over 100,000 people died from drug overdoses, an increase of approximately 30% since 2019, which is really a serious issue. I want to also give you a historical background of the opioids problem in our country. As you may all know, the opiate phenomena was originally characterized as having 3 waves, but now we are in the midst of the 4th wave. The first wave was identified between 1990 and 2010, where we witnessed an increase in overdose rates from prescription opioids that use illegally. The second wave of the opiate epidemic occurred between 2010 and 2013, where there was a reduction in the number of opioid prescriptions, yet we see more deaths because of heroin use. The third wave began in 2013, where we see more deaths attributed to synthetic opioids, such as fentanyl, which is 100 times more potent than heroin. And now we are in wave 4, and ample evidence and data showing us that now we have a new epidemic, which is focusing on methamphetamine, more crack cocaine, more stimulant use, more benzo with fentanyl. So here we see how the historical background of the pandemic increases and moved to a wave 4 that even impacted a totally different populations. I also want to mention that I work closely with Millennium Health. It's an organization that monitors drug use over time. And only a few weeks ago, they shared with me very disturbing data. For example, what they showed me that between 2019 and 2021, use of illicit fentanyl increased by 155% in individuals who use methamphetamines. And use of illicit fentanyl increased 81% in individuals who use cocaine and 42% in individuals who used heroin. So what's happening in the 4th wave of this pandemic? Yes, more different types of drugs are used. However, we also see that drug overdose deaths are increasing fastest among people aged 35 and 44. Another phase to the epidemic that we see in the 4th wave, that the rate of drug overdose death among non-Hispanic Blacks are increasing the fastest. And look at this figure, and you see that among non-Hispanic Blacks, which is the green line, we see that in 2015, the rate of death per 100,000 among non-Hispanic Blacks was 12.2. And if you look at the 2020, the rate of overdose death per 100,000 increased to 35.4, which an increase of 190%. If you look among Hispanics, we see that almost the same story. In 2015, the rate of drug overdose death per 100,000 was 7.7 and increased to 17.6 per 100,000 in 2020, which an increase of 130%. However, if you look at the white population, you'll see non-Hispanic whites in 2015, the rate of death per 100,000 was 21 and increased to 32.8 per 100,000, which an increase of 55%. Here you see a different phase of the epidemic. Again, the opioid epidemic impacting the community of color. So I want to start by telling you about the largest NIH-funded research to use the community to address the huge problem that impacting our community. This study, it's called the Healing Community Study. It was funded in 2019, and it was funded to 4 states, Kentucky, Ohio, New York, and Massachusetts. It's funded to deal with the opioid crisis in 67 communities that are heavily impacted by the opioid crisis, and it includes the 10 million populations. As I mentioned earlier, the purpose of this huge community-based research is to reduce overdose death by 40% over 3 years, but we also have a number of secondary outcomes, such as increasing naloxone distribution. As you all know, naloxone is a medication that saves lives. Also to increase access and utilization of medication for opioid use disorder and decrease high-risk opioid prescribing. As you see here, the study funded in 2019, only 6 months before the COVID pandemic. And then later I'll talk about some of the challenges we faced. But from a scientific point of view, I want to briefly tell you about the design of the study. It's a multi-site, it's parallel arm cluster randomized trial with waitlist control trial. What this means that in 50% of the 67 communities were randomized to the intervention arm at the end of 2019 to receive a community-based intervention for more than 2.5 years, which we call it wave 1. And then after 2.5 years, wave 2, the waitlist communities receive the intervention. And our purpose is to compare the primary hypothesis, the primary outcomes between wave 1 and wave 2. So what is the intervention? And I want you to pay attention about the intervention. It's community-based intervention. And here is our model. In every county we go to in wave 1, we create a coalition that is charged to deploy data-driven evidence-based practices for 2.5 years. Again, I want you to pay attention. I'm using the word data-driven evidence-based practices, and I'll explain it in a minute. The coalition consists of 15 to 40 members, and it depends on the size of the community. And every community hires data manager and experts on data and a coordinator that work closely with the community. In this coalition, we have policymakers, we have health and substance abuse providers, people with lived experience, family members of those lost of overdose, and local government officials who are sitting on the same table to decide the best practices to reduce overdose death in 40% in their unique county or community. However, we know that there are evidence-based practices that work well, and we ask every coalition to consider 4 of them. 1, we ask the coalition to consider expanding overdose education and naloxone distribution in their counties. We also require that they improve access to medication for opioid use disorder treatment. We also ask them to look at safe opioid prescribing and also to address stigma, which is really a huge problem. Stigma against people who use drugs, those on medication for opioid use disorder, and those who even carry naloxone. We also require the coalition to consider multiple sectors that they work with. We ask them to focus on the healthcare system, and our definition is very broad. We require that the coalition works with EMS, emergency departments, hospitals, health departments, pharmacies, and primary care. We also ask them to consider the criminal justice system, and not only to work with the law enforcement, the police, but also to include pre-trial programs, drug court, opioid courts, correctional facilities, alternative to incarceration programs, and also work with halfway houses. And the third sector that we ask them to work with is behavioral health, substance abuse treatment, social services, mental health treatment, shelters, harm reduction programs. So there is a mission that they need to address. It's not only working with one sector, but working with multiple sectors to deliver and deploy evidence-based practices to reduce overdose deaths. We also create a community advisory board. The community advisory board its role is to provide the researchers with guidelines and to oversee the work of the researchers. The community advisory board consists of the highest level of governmental officials, as well as industrial group, and also people with experiences of substance use. And we also require them to use data to oversee the implementation of our implementation. Also want to share with you a creative approach that guided our thinking. We use the collective impact model. I'm sure many of you are familiar with it. In this model, we see the backbone of the study is the official government, which is the local government, either the Commissioner of Health or the Commissioner of Mental Health. We put the coalition within the Commissioner office. We also, the coalition required to build upon pre-existing capacity and strengths of the communities, because many of the communities have strengths and have already built a structure to address the opioid crisis. And we ask them to build on this strength. We also provide them with guidelines to share a common vision, common approach, and joint approach to solving the issue. We also reinforce shared measurement. We ask the coalition to assess the process and outcomes for what they're doing for accountability purposes, as well as to continue building trust and communication. And I want to mention here, you'll see in a minute, research and data are critical components of the approach. We work from day one with the coalition to access data that they need. And we also hired, as I mentioned earlier, a data manager who is an expert in data to be able to respond to the evidence-based approach. We also go beyond community-based participatory research. One of our mission is to overcome health and racial inequities by reaching out to all communities. We create a model that promotes co-learning. They have to learn together, co-designing with all entities within the county. It's about consensus-driven plans for the solution. They need to look at the data and come up with a consensus about what the best solution in a given time for a given county. It's about data-driven implementation process of evidence-based practices. It's also about sustainability plan. The study is designed to make sure when we're done with the study in 2.5 years on the intervention, we build systems in place to allow the programs that we design to sustain over time. Now, I really want to highlight that the innovation behind this study is a data-driven approach. And let me begin by let you know that in every county, we create a portal for the coalition to use. In this portal, the coalition can access the rosters, the agenda. They can also access a community profile and landscape data reports. We, as researchers working with the coalition to collect landscape analysis about what's happening within each community in terms of access to treatment, access to services, in terms of are we accessing all communities? And we use a dashboard where we put all this information in the dashboard, and we use data visualization where the coalition, every coalition is trained to use data visualization to make an informed decision about what the best practices to implement in their community. The landscape analysis is being done on an ongoing basis. We revise it to inform the changes that occurring in the community. We also use data science to help the community to make informed data-driven decisions. We have experts in our group on agent-based modeling, and we have experts in system dynamic modeling. They're working closely with the researchers and working closely with the coalition to provide this information. And also in the dashboard, we put a very intensive really evaluation of on ongoing basis about the progress that they're making. This is to give you an example when I say data-driven decision-making. On an ongoing basis, we provide from the county local data on number of fatal and non-fatal overdose, and we provide this data by race, ethnicity, and gender so the coalition can see the progress. We also provide data on number of people on medication for opioid use disorder, number of prescribers by healthcare location. And again, in ongoing basis, the landscape data is placed in the dashboard so they can be used to make an informed decision. Here is the data science, which I think it's one of the innovation of the research. And I mentioned earlier, we use agent-based modeling. It's really about predicting, forecasting how much intervention each county needs to achieve the reduction of overdose by 40%. Do they need to have 5 times increase in medication for opioid use disorder? How many kits of naloxone they need to distribute and where in order to achieve the 40%. So this model of forecasting, predicting, using simulation model, use data from 2012 to 2020 to predict what needs to be done. This model is shared by the coalition. We train the coalition how to use it, and it's put in their dashboard so they can use it. There's some counties that realize they need to increase their medication for opioid use disorder for their county more than 7 times, and they need to increase the distribution of naloxone kits more than 8,000 kits. So if each county looks at this data and they make a decision how far they need to go in order to achieve the major outcomes of the study. Another innovative data science approach that we take is the system dynamic modeling, which really is about using both qualitative and quantitative data, even the minutes and the discussion that the coalition had, to look at challenges, to look at identify systems that they need to work with, the barriers of the systems in deploying evidence-based practices, and also on sustaining what we're doing. We have an expert in data system and system dynamic modeling that use causal loop diagrams, as you see here, to identify how systems work, which systems we need to work with, how we predict that the system are the best system to deliver the evidence-based practices. We train the coalition to look at this data, but the most powerful piece of this approach is that the data are collected from the community, the data are collected from the coalitions, we analyze the minutes, and we use the qualitative interviews that we collect on an ongoing basis. We also use the landscape analysis to come up with these causal loop diagrams to make very informed evidence-based approaches to identify the best systems that the coalition required to work with. Now, so I gave you a background of data-driven approach. I gave you a background of the study. Now I thought it would be a good idea for me to share with you how we apply it. What are the evidence-based practices that we used? I want to give you a number of examples from overdose prevention and naloxone distribution, and also about a medication for opioid use disorder. And I want to talk to you about the involvement of the healthcare system as well as the law enforcement. And here is the first strategy. One county decided they need to, more than one county decided that they need to identify hotspots to distribute naloxone. So they use data from multiple sources, for example, from the high intensity drug trafficking areas. They also use data from the emergency room to really define where they need to go to distribute naloxone. I know well, and we all know that our state distribute a lot of naloxone, and we want to build on the strengths of our state, but we also want to identify additional locations. And here, what many of the counties decided to go. They decided to intensify distribution of naloxone in motels, in homeless shelters. They also want to increase the naloxone distribution in community rail stations, on parking lots, gas stations, jails at release, and also increase mail naloxone, especially during COVID when people could not be around to get the naloxone. So, so these are really the locations, according to the coalitions, that they decided are at risk locations that we need to bombard the counties with naloxone. Now, in terms of what we see so far from May 2020 to February 2022, 2,977 individuals trained to distribute naloxone and 9,294 kits distributed by the study. I also want to mention that, as I said earlier, our state distribute more, and this is in addition to what the state has been doing. Another creative solution to an evidence-based approach is increasing nalox box placement. I'm not sure if how many of you heard about nalox box and to save lives. Nalox box can be a box that can be secured on the wall with naloxone, and people can access naloxone 24/7. So naloxone box that it can put on the wall contains 7 to 8 doses of naloxone, which also gives instruction of how to use it, and also some cards of referral to treatment. It's really very innovative. So if one takes a nalox box, they have all this information. And if they're interested in the link to care or link their network members into care, they have enough information to do it. It's also improved the capacity of bystanders to save lives. That's really important. That's one of the key mission of the coalition, to improve the capacity of the bystanders to save lives. It's also about normalizing access to this overdose reversal tool. And so far, the locations that have been used to place nalox box are local community areas, department stores, restaurants, small business, and motels. So the Healing Community Studies supported the installation of 360 nalox box in 8 counties from January 2021 and March 2022. We're learning a lot how this nalox box is so important and how the community appreciates very much the access to naloxone. And because it's placed on the wall 24/7, it can also improve the capacity of the family members to get it when they need it. Here, it's an example which I really love to share with you. It's one of my favorite examples, is putting naloxone boxes in 2 motels in one community. The motels are located in the neighborhood where there's so much overdose death, and the rate in this, where the rate of overdose death in these 2 motels areas so high. So what we did there, we put them, and the housekeeping checks every nalox box during room cleaning, which I thought is very innovative. And we so far replaced from January 2022, replaced 49 nalox boxes in these 2 motels. I am hoping I'm hoping that more counties in the healing community study will pursue naloxone boxes. We cannot force the coalition to go around and add nalox boxes in the motels. We provide the evidence base, and it's up to the coalition to do it. But we're seeing some movement now that more counties are interested in pursuing this innovative life-saving approach. Now, I want to talk to you a little bit about how we work with the healthcare system. How do we apply as a study the evidence-based practices? I want to give you two examples, which one is about comprehensive approach in psychiatry emergency program and one in psychiatry unit in a hospital. And the other example I want to share with you is urgent care center, where we provide medication for opioid use disorder and community mental health. These examples give you about how broad strategies the healing community study approaching and promoting. We, again, give the opportunity to the coalition decide. And a number of coalitions decided they want to focus on the healthcare system, and we provide them with resources and data and technical assistance to be able to expand medication for opioid use disorder in these settings. Let me give you an example of one hospital. Again, this is a hospital that in a county that they decided to bring medication for opioid disorder in the psychiatry emergency program. We provided training for 6 psychiatrists to deliver medication for opioid use disorder in this hospital, and also linking people to care, especially to drug treatment prior to the release. What happened in this unit in the hospital, the psychiatrists with the nurses work on identifying patients that need medication for opioid use disorder. They provide them with a medication for opioid use disorder in the unit before they are discharged. And when they discharge, they link them to care, and they do follow-up appointment. And they also distribute naloxone kits to patients, to family members at the times of the discharge. It's a new approach for this hospital. And we see that in the past 6 months, there are 36 linkages and patients that receive this intervention. We talked to the 6 psychiatrists, we talked to the administration in this hospital, and we see that there is so potential to expand this work, and there's so much excitement in the community. And we heard from the family of the patients who were discharged are really excited to be part of the solution prior to discharge of the client. So this hospital is going to go far with this model. Another approach is a hospital decided to increase a prescription of medication for opioid use disorder and linkage to care in inpatient unit, a psychiatric unit. Again, we provided a support, we provided a training, and the hospital was able to provide funding to hire a peer navigator in the unit. So this peer navigator worked with each patients who have a substance abuse problem and need support, and work with them by linking them to care, but also stay in touch with them and their family. So the peer navigators work in the psychiatric units with the psychiatrists who were trained to prescribe medication and work on substance abuse issues. So far, in the last 4 months, this unit worked with 46 patients. And we have been talking to the hospital and this unit, and we see a great potential to expand this work further. This is really another innovative approach that one community decided to pursue, which putting a substance abuse treatment in urgent care center. One county integrated medication for opioid use assessment and linkage during 24/7. They hired a person, and the study provided funding and the training to hire this person. And since September until now, there are 12 individuals are named. It's going very slow, but we are seeing transformation of the cultural shift in how urgent care center can focus on delivering medication for opioid use disorder, as well as working with people with substance abuse issues. There is so much excitement, and we as a study are hoping to see other counties that can use this model to deliver access to treatment. Now, another approach one county decided to use is a community mental health clinic, integration of substance abuse with mental health clinic. And here they hired a staff member to be able to provide a treatment with mental health treatment. This is a new concept in this community mental health clinic. It's going very well, and we're also hoping that they will be expanded to other counties. Now, another really creative model that I want to share with you, and I'm really excited about this county. One county decided to work with people on the street who have no place to live, and they have substance abuse issues. And they decided with the healing community study to provide vouchers to people on the street. And these vouchers provide them with resources to stay in motels. However, with an agreement that they agree to be linked to medication for opioid use disorder and other services. This county established this program, and right now, only from November 2020 till now, we're seeing a lot of progress in this area. So far, we provided vouchers to 101 individuals who went to the motels with an agreement to be linked to care. 91 people initiated medication for opioid use disorder, and 91% returned in treatment for 6 months, and we're following up to see how this is going to go. We're hoping that this model can be applied to other counties. This is the only one that we are working with, but the concept is so innovative. It addresses health disparity issues, and it's really a low threshold kind of approach where you can give this voucher, link people to care, have a social worker to work with them, and help them to stay in care. So now I want to move to talk about how we involve the law enforcement and give you a few models of the involvement of the police. Here, it's a model that has been working so well. In one county, the police, who cares a lot about addressing the opioid crisis in their community, because this sheriff had family members who are impacted by the opioid issues, and he wanted to make a difference in his county. So he was able to work with the healing community study and get funding to work with a social worker who is deployed during the arrest process when a drug opioid use is involved. The police go out with the social worker. They use iPad as social workers, and she makes the linkage to care immediately with an emergency medicine physician to prescribe buprenorphine and also refer to treatment and to harm reduction programs. The social worker continues her relationship with the person over time and ensure that the person is linked to care. We're really very excited about this model, and the county itself and the commissioner of the county is willing to sustain this program because they see how important for the community. Another approach that one county decided to pursue is to create an opioid court. And many of you may know, opioid court is a pre-plea voluntary model that can serve as a medical triage for any person at high risk for overdose. So in this case, for the opioid court, incarceration is deferred, and medication for opioid use disorder is delivered immediately. So why this county decided to create this opioid court? Because in the coalition, we have a judge who sits in the coalition, and he decided to pursue this model. The judge and the coalition found resources and opened this drug court, and it's a new one. It's launched in on March 14th, and we're hoping that will make a difference. Now, the last component that I want to talk to you and to show you how the healing community study is addressing the issue of stigma. We are involved in a number of campaigns to reduce stigma. We have at least 4 for now. The first campaign is to increase demand for naloxone, increase access to and availability of naloxone. That still we need to do more. With this campaign, the coalition trying to get into people with lived experience, community leaders, providers, to understand how important to access naloxone everywhere for people who need them. The campaign too is anti-stigma campaign to reduce people who are on medication for opioid use disorder or people who have substance abuse problems. Again, it's a campaign that is designed to reach to the community. The third one is to increase demand for medication for opioid use disorder and increase also prescribing medication for opioid use disorder. And the final one is really increase support to stay in treatment, to support people who want to recover, stay in recovery, and also address issues of barriers that they face, as well as link them to harm reduction and other programs. Here, the communication campaigns is distribution. We use paid media to deliver the messages about stigma reduction. We use advertisement on social media, Facebook, Instagram, radio or television, direct mail, billboard, posters, movie theaters, gas stations, and we also use coffee sleeves, palm cards to get into to get the messages into the community. We also use unpaid media. As you see in this slide, the biggest one is press releases that the community provide. Here, it gives you some really ideas, information about how we place the messages. For example, this person that you see here who said, I'm a strength, I'm a hope, I'm not alone. I took buprenorphine and I'm in recovery. This person is so known in the community and is well respected. And by putting his messages on everywhere in a specific county, it created a dialogue in the counties about how important to access treatment and to help people who need treatment. This is also a few of the messages we put everywhere. And this is a doctor who prescribed a medication for opioid use disorder. She's known in her community, and she agreed to be put her in buses, billboards, and talking about how important to access treatment for people who need treatment for opioid use disorder. And this person also who said, I'm proud veteran, volunteer, and grandfather, I also take buprenorphine. Again, this person is so known in the community, and by exposing himself everywhere, it created a dialogue in the community to talk about stigma and allowing the conversation about substance use to be out there and people not being afraid to talk about it. This also unpaid media highlights. The coalition writes a lot, publish a lot in their local newspapers to get the messages outside in the community and with an emphasis on stigma reduction. So what you see here, to give you some ideas, we have more than 5 million impressions since March 2020 and more than 14,000 clicks on the website since March 2020. And we are in the process of assessing whether or not our media campaigns to reduce stigma made a difference. We have a methodology behind it, community-based approach, and because it's a clinical trial, I can't talk to you about the impact yet of the outcomes, but in a year from now, I can come back to you and tell you about whether or not we made an impact in terms of the reduction of overdose deaths. So we're hoping that we will see stigma reduction because of these strategies. So let me end here by talking about take-home messages. I described to you a community-based research where the community is not study participants, but the community is an integral part of the research as making decisions about what the best approach for their community. It's an approach that we need all voices to be heard, have everyone to have a seat at the table. We express diversity of voices, which is a key ingredient of community-based approach. And what I also described to you, it's a data access, which is really a critical component of the approach that we're using. It's very challenging, and it's to get data and update data on an ongoing basis. But it's a commitment of the Healing Community Study to improve data access. So it's one of our goals. And in a number of counties, we see better collaboration with the medical examiners, better collaboration with the coroners to get the data on an ongoing basis to the coalitions to make a decision. But I don't want you to get the message that an easy job to get data on an ongoing basis. There's so much to be done in improving data access. And it's one of the most challenging data to timeliness of the data. And over those data, it takes a while to get it. And because of system barriers and other barriers that prevent people from accessing the data. And I'm hoping that through the Healing Community Study, we can provide a significant role in improving data access. So another piece that I want to highlight, as I started my presentation by talking about the historical piece of the opioid issues, now it's not a problem of a white community as we have talked about it and we pursue it. And for many years, it's the opioid crisis is a white community. It's not. It's really a problem that's impacting our community. And we have also to remember historically how our communities, all communities, community of color have been impacted by opiates and other substance abuse issues. The other piece that I want to highlight that we have a huge commitment to get to all community and to continue seeing the problem as public health problem and not as a punitive issue as we have treated the crack cocaine problem and historically and other substance use problems that impacted our community, where we use more really law enforcement to address it instead of looking at it as a public health issue that the Healing Community Study really underscoring it. And the last thing I want to talk about is this work cannot be done with one profession or one person. In order to implement such a large, diverse, community-based research, when I wrote the grant, and I knew from the beginning that School of Social Work by itself is not going to be enough given the multidisciplinary nature of the study. So here we brought social work with psychiatry, with public health, with data science, information technology. We also work with our colleagues who are experts in data science from different universities in New York State. And also I want to say that this work cannot be done without a close collaboration with both the state government and the local government. Local government, I mean the commissioners of mental health of each counties or health, but also we're working closely with New York State Office of Addiction Services and Support. A lot of support we get from them and a lot of energy that they provide us to implement the research. We work closely with New York State Department of Health, and also we work with, again, the 16 health and mental health commissioners of each county. I give you really, it's 45 minutes, but it's a really brief kind of overview of the study. It's a large study, and we have been publishing about the intervention itself, about the methodology, about the challenges we're facing, about the sustainability issues. And we produce a special issue. If you want to learn more about the study, please visit this special issue. Unfortunately, I cannot yet share the outcomes, given that we're in the midst of the study, but hopefully in the future, I can come back and share with you more about the outcomes. But if you need to learn more, here are a number of references that you can use. One of our mission is to publish on an ongoing basis, to be able to share with the community and to share with our colleagues about the progress and barriers that we face in addressing this issue. So thank you, and let me stop here and answer any questions that you may have.
Thank you so much, Dr. El-Bassel, for this wonderful presentation. We have already received like several questions in the Q&A, and I'll start with some of them. I know we have like about 10 minutes, so we might not get to all of the questions. So one of the first questions that we got is like, if you could say more about the community participation in decision making and in the HEAL project, because it seems so critical for the success of the whole initiative. So if you could talk a little bit more about that. Yeah.
You know, how we define a community is a county, and we work with 16 counties. And in wave one, we have 8 counties. We go to the county, and first thing we work with the commissioner, either the mental health or health commissioner, and we ask them to tell us if they have a coalition that they work with. In many counties, they don't. And we go around and ask about all the key players in the county that can help us to get into the stakeholders, into people with lived experience, and start building the coalition. We build the coalition to ensure that it has representatives from all the sectors and all the community. I tell you honestly, one of the challenges that we're facing is to have enough people with lived experience in the coalition. We, in wave 2, one of my mission is to increase number of people with lived experience. And you may ask why we having the, is cultural shift to have the community voices out there. And secondly, if we have law enforcement and we do have the commissioners and other key players sitting in the room, maybe the people with lived experience feel uncomfortable to be part of the community. But having said that, we do a lot of technical assistance. We work closely with the members of the coalition to create a safe environment in which every person can feel comfortable to be part of the community. And so in wave 2, we will make an effort, more effort, to ensure that we have more people with lived experience and people of color. In New York is different than Kentucky, Ohio, and we have more people of color. We have more community of color who are impacted by it. So we have strategies in place to ensure that their voices are included and their participation in the coalition is integrated.
Thank you. Another interesting question from the audience is if you could talk a little bit more about how you got the buy-in from law enforcement and the criminal justice system to participate as part of the study in the different counties. Yeah.
Yes. Let me start by saying we are successful in some counties and other we face challenges. In at least 3 counties, the law enforcement were ready because the sheriffs have experience, as I mentioned earlier, in their families, and they tend to be people of color who have experience in opioid use disorder in their families, and they struggle and lost people in their communities. And so we invited them to be part of the coalition, and they were become an integral part of the coalition. And that's where they start seeing the importance. The more they're integrated into the coalition, the more they know about the issue, the more they have family members or their network impacted by it, they're more likely to be humane and being able to be an integral part of the coalition. And there is one county that we invited a law enforcement person, a sheriff, to be part of it. He was very difficult. And at the end, we faced challenges with this county, and we're still trying very hard to integrate, and because we want to create a safe environment for other people who are sitting on the table too. Now, I think the most important piece I want to mention to you, when we involve the law enforcement, I really do believe strongly with the model I presented to have a social worker integrated with the law enforcement. And you know, now we have a new law that it will be active in, I believe, in October, where all criminal justice settings, jails, prisons, will have to deliver medication for opioid use disorder. Thank you for our governor, and they will have the law very soon. And so this also helped us to integrate more prisons and jails with us, especially jails with us, to address the issue. The other piece I want to mention is that we also hired peer navigators to be outside the jail to connect with people where the law enforcement saw this kind of important role that we have to link people to care, and the law enforcement became more involved. I can talk for hours about challenges and really also strength of the approach, and I'm really hopeful.
That is great. And then like we have another really interesting question. So from the audience, so they mentioned that certain nonprofits such as a Corner Project in Washington Heights are providing a safe environment for drug use to promote harm reduction. And they would like to know if you see expansion of these organizations or this type of organization being more socially acceptable.
Yeah, first thing I'd say, I'm so excited about what is happening in our city here, and also I'm always proud of to talk about what we have in the city with other states, Kentucky and Ohio, and to see what's happening, and we need to expand this service. Yes, we're talking about it. We discuss it in a number of coalitions. I'm hoping that some transformation will happen and we'll have the same service in other states, but it's not, we don't have them yet, and hopefully we will. It's really very exciting.
Yes, it sure is. Another question, like we keep getting several questions from the audience. Yeah. So one of the persons in the audience wants to know, like, what is your advice on helping to get Narcan and fentanyl testing trips better distributed among local businesses?
Yeah, that's really a very, very important question. And I have to say that when we started with the study, we didn't have FTS to distribute, and now we're going to get a supplement to be able to distribute FTS through the coalitions to different community and agencies and service providers in the community, because it's really to save lives. We need people to have access to FTS, given what we're seeing in the fentanyl test. We need to do more, in fact, this is a good question, more marketing into it and more educating the community. We are having a campaign, additional to the campaign that I didn't talk about. The fifth one is about distribution of naloxone in different settings, including the industry and including providers. So will be a campaign about this. We know it's a challenge, and stigma is huge, but that's one of our next stigma campaign about really improving access to fentanyl test strips.
Wonderful. Then I think a final question. Could you talk a little bit more about whether you are providing the same intervention for Wave 2 of the project? Yeah.
This is a great question. This is an amazing question. I would say we're providing a more powerful intervention because the design is waitlist design, meaning we can be creative and innovative and learn from our experience to deliver a better intervention. So everything we've learned and the mistakes we made and the scientific aspect of the study will be informing us to deliver a better intervention. We began our deliberation in how to improve the protocol, and we're hoping that Wave 2 will get better one. And we also, I don't want to end without saying that we want to sustain what we created. So we're working with SAMHSA and other organizations to make sure when we're done with Wave 2, so sustainability and dissemination are part of our goal. So, but yeah, they'll get a better intervention.
That is really great, great to hear. Like, I think we have time like for one more question. Like we have 1 more minute. So one person in the audience wanted to know a little bit more details about whether the nalox box could be opened by anyone or if there was a lock.
No, it's opened by anyone. There is no lock and no system that they need to know or no password. It can be, yeah, anyone can use it, which is really very exciting.
Yes, it surely is. Well, I think we're at the hour. Thank you so much. Thank you so much, Dr. El-Bassel, for this wonderful presentation today. And Thank you for the audience, and please reach out to Dr. El-Bassel if you have further questions.
Thank you.